they pretty much can look at us and see that we're homeless. The people with all the bags and the duffel bags, suitcases or whatever. You know, don't be scared of us. You know, we're not gonna hurt y'all. You know, we're who we are. We're y'all. We're just like y'all. You know.
Traumatizing. I think I have resuscitated more people out here in the streets than I did at work when I was a nurse. Isn't that crazy? With the needle still stuck in their arm. And guess what? When I'm done, they'll get up and they'll go do it again. Who does that?
Everybody in San Antonio looks at me like I'm a fucking criminal and like I'm the worst thing ever. It's not everybody's fault they're out here. A lot of people, granted, don't want to leave the streets. They like it. It's not where I want to be. I've been pushed around and thrown to the side, and everybody wants to say they can help you, but when you ask them to do it, they don't. If they did, I wouldn't be out here.
I was attacked by a vicious dog, and it was life-threatening. I had to get emergency surgery. Just me kind of like running around trying to figure out what to do, but since finding street med, it's been perfect. They've been awesome. They've been perfect. They've been on point with everything. They've done everything fast. They know exactly what to do.
San Antonio Street Meds was one of them that was my very first, only because when we came out here, we were met with a young lady named Maria. I knew her for 7 years, and she got very ill after the last winter. I did not know who to contact. I didn't know who to call. So I started asking organizations, and they directed me to San Antonio Street Meds. And from there, I've been working with them. They have been able to take care of a lot of our homeless that have a need, a medical need. So they've become a very good partner, very useful partner, and one that has really shifted the way I see our organizations working together.
The street medicine programs across the country are very different. Some are full-time, paid with their own cars and offices and full-time folks. We are almost completely the opposite of that here in San Antonio. We're all volunteer. We drive our own vehicles. We're all self-funded. So that presents certain limitations, but also a lot of freedom. I joined Street Medicine San Antonio in May of 2019. The program itself was started in January of 2019 by Dr. Hans Bruntmeyer, another emergency physician. He has since moved out of town to Michigan, but he was really the genesis. And we've steadily grown since then from pretty humble beginnings to still fairly humble present, but there's been definitely a lot of progress and change over that time. So Hans initially started going out on his own and was teaching over at UIW's School of Osteopathic Medicine, and started taking out some of his students, medical students, through the outreach medical interest group there. That has steadily grown into also hosting UT Health nursing students and several residency programs in the area, including UT Health, internal medicine, family practice residents from the Christus Rosa system, and Tigmer interns from the psychiatry program that they sponsor. So that's really introduced a significant learning piece into our service piece of street medicine. The impetus for me getting involved personally, honestly, was I was challenged by one of the residents I work with at Brooke Army Medical Center. And we were just talking one day on shift and about, hey, what do you do to serve the community, specifically in the setting of faith? The idea is you're given certain talents and you're meant to use those to serve others. And so he was kind of challenging me like, hey, how are you doing that? And I was like, I don't know, how am I doing that? And so then I started thinking about what can I do with my medical talents to serve the community. And my particular experiences with the military as an ER physician, serving with Special Forces overseas in a far forward capacity, wearing backpacks, working in austere environments, kind of led me to wonder, like, hey, that's kind of a special skill set. Could I apply that here, and if so, how?
I'd gone a lot of places around the world and done a lot of different medical care, and I kind of thought, you know, we go to the airport to go to these different places around the world, and we drive right by or step over, so to speak, people who are living just like these people we're going over to help. And so I kind of had gotten tired of traveling around the world, and I thought this would be a way to take care of people right in my own backyard. In medicine, because of the way the system is set up and the demands that are placed on people, you tend to get burned out. And you have all these things you can do, you can't do, you have to document this and not document that. And, you have to see so many patients in a time frame, and people start burning out. And what we found was when people would come out with us on the street, it would ignite them and let them know, oh yeah, this is really why I went into medicine.
I lead a team along with other team leads. There are about 6 of us right now, and we take residents and medical students out with us, nursing students as well. And we bring all of our wound care supplies as well as medicine in backpacks. So everything that we need, we carry on our backs so that we are more mobile and can meet the patients under bridges or in more obscure places. And we have the capability to do basic wound care. We can also drain abscesses. Our medications can treat general infections, pain. With over-the-counter pain medications, we can treat skin issues. We have topical antibiotics. And we also have other meds such as allergy medications. And I think that is about it right now.
Street medicine is extremely variable, what we run into, which makes it kind of fun, especially as an ER doc. We kind of like some variety and problem solving, but we do a lot of wound care. Some respiratory and GI complaints are common, joint musculoskeletal problems are common, but a lot of care coordination too, sometimes just helping people and their outreach workers who are advocating for them, what are their real needs and how can they what are they eligible for, whether it's VA or getting them plugged into CareLink or Medicare or Medicaid, or do they just need a prescription refill? And if we call it in, can they pay for it? Sometimes they'll pay for their own prescriptions if they're cheap. Can one of the local charity organizations pay for it? If somebody needs surgery, what are the barriers to getting surgery? How do we do it? Where do we do it? Helping them understand the doctor talk and navigating the system, which is extremely bureaucratic and frustrating. And for people who many of our folks have substance abuse and mental health issues, having the patience to work through a complicated bureaucratic system is really beyond them. And then throw in that they may or may not have good access to a phone or a computer, so trying to navigate a system that assumes that you have access to all those things, and even then you're going to be put on hold and have to fill out 40 forms, it just becomes a barrier that they can't handle on their own. And so helping them try to work through that is a role that has been productive for us.
For almost every patient we meet, we're plugging them into other resources, be it SAM Ministries or the city of San Antonio, so that they can meet with their case managers and address more of the social services component to it. So we're being an interdisciplinary, multi-specialty team is a big piece of street medicine. We also have physicians that we have consulted in the past that have done pro bono surgeries for a few patients. We've had other dermatologists that have weighed in on some chronic skin conditions that were stumping us as far as what they were and how can we treat this.
But it's really variable. So we'll go out and try to meet a patient. Many times these patient populations not super reliable, so they're not there, so we have to reschedule, or we're there and other people come up with new concerns like, hey, you're seeing Jim, can you see me for this? And then we have to pivot and look at something new. So it's a lot of problem solving, a lot of different approaches out there, but it's fun when we can actually help people get through. And it has been interesting because initially we would just go out into camps and walk around and try to find people and go, hey, do you need any help? Which was super inefficient. But over time, as our organization's gotten known in the community we serve, the outreach workers especially have been really good about giving us referrals. Sometimes other people who are living in camps will give us referrals about their campmates. The police have given us several referrals of people they deal with who need help. And so now we mostly already have a pre-planned list of people that we're going out to see.
For mental health, in the past, we've been able to work with mental health patients as well, and we are working on being able to treat those more regularly on the street, but that will depend on the amount of rounds that we can do so that we can provide regular care and checkups, especially in light of those medications, which can be dangerous if you're not out often enough to check on them.
And seeing vulnerable populations in their own element and seeing what they're dealing with and why they're struggling as much as they are, and hearing their life stories, I think is it helps me regularly reset my compassion level, and certainly I think helps them to understand the people that they may see in the hospitals or the clinics, what they may be dealing with, and maybe approach them in a different manner. There's a lot of help out there for people who are in need, and different organizations, but it's very fragmented and very difficult to access sometimes. And I think for street medicine, our special niche, if you will, is to find those folks who can't or aren't able to get to a fixed healthcare facility, and we go to them.
They say there's too many people, they don't have enough time, it's more work than they can handle. I'm in this situation this time that I lost my housing because Saha didn't do their job. They did not tell me that my rate had changed. They did not tell me that my landlord would stop renewing my lease. If they would have, I would have found another place, plain and simple. I went 6 months not knowing that they didn't renew my lease. I went to my landlord's office every month and paid my water bill. And nobody said a word in 6 months. What am I supposed to do?
I'm trying to help everybody with everything, with the little that I do have, because the Lord sends me more blessings. I help people out here and there. Like Kool-Aid, I used to do his wound. He had 45% of his body burned. Somebody set him on fire.
It happened about a month ago. A lady that I knew. She also was friends with one of my real good friends named Eric. Them two had altercations. They were arguing back and forth about something that happened years ago. And both of them wanted me to take their side, and I wouldn't. I was like, I didn't know y'all then. You know, I have nothing to do with that. And even, you know, I just didn't want to be bothered with it. And she made a statement to me. She wanted me to take her side. And I didn't think she was gonna set me on fire. You know, and one morning she walked past my tent and she set me on fire.
They interviewed two guys that pulled him out, and they said the woman was in the background just screaming at him, "Don't help him, don't help him, let him burn, let him burn."
I went to Bamsey and I had surgery. They had to do the skin graft, fix the skin that was burned on my leg. I had 3rd and 4th degree burns. After the hospital, I went to it's like something like a shelter, but it was housed by Sam Ministries. It was a hotel. When I got there, they knew I had been through. My legs had been burned. My mobility was less than none. I didn't have great mobility at all. I had enough strength and mobility to get up, maybe walk to the restroom real slow or whatever. But I just didn't. I didn't like being harassed every day about getting up, doing things that they know would be, you know, painful to me. You know, I didn't see where that made sense to me. They knew I was in pain. They knew my legs had been burned. You know, and they would just come into my room every day, just bothering me. So after about 5 days, I got up and I left.
But you told me you were on certain medications.
Oh yeah,
Was
take care
that
of
was
dog.
in Chicago? Do
Oh,
you
yeah, when I was in jail.
That was from when you were in jail.
We kind of act as primary care folks for those people until they can get plugged into Medicare, Medicaid, VA, whatever they're eligible for, which often can take months. And that's where we've gotten into things like becoming a PCP and writing orders for oxygen, which I, as an ER doc, never have done. But it's amazing to me how difficult that can be for just a simple thing, and for people who are really challenged. I don't know how they would ever do it, because it was really difficult for me as somebody who's a healthcare provider and has access to everything, phone, communications. And ultimately it just took talking to the right person after like 20 calls, talked to a supervisor, and she's like, oh, we can have this done next week, and she did. I was like, well, that was easy. Why was that so hard for the last 2 months?
In a government sense, there's a lot of types of homelessness and what you qualify for in homelessness. So if you're in a shelter, yes, you're in a shelter, but you're still considered homeless if you're living on the street, if you're in a car, if you're staying on someone's couch and couch surfing, if you've been homeless in somewhere you're like basically living somewhere that is not meant for habitation. And then your length of homelessness matters, right? So if you qualify for permanent supportive housing, let's say you have severe mental illness and you've been homeless for more than a year, you would qualify for permanent supportive housing, or potentially qualify for that. If you qualify for rapid rehousing, like are you homeless but you have a job, and you might qualify for getting housing assistance to get into an apartment, and they pay for so much. But there's different types of homelessness, and I think sometimes that is also confusing for someone who's experiencing homeless. Like, I'm homeless, I need help, whether I'm sleeping in my car or I'm living somewhere like couch surfing, and some nights I sleep on the street and some nights I sleep in a hotel. I'm still homeless, I still don't have a stable place. Or for the hospital setting, we have people that often stay in a hospital, and if you've been in a hospital longer than a certain time period, you're no longer considered homeless. But when you leave that hospital, you have nowhere to go. Or if you've been in jail for a certain amount of time, you're no longer considered homeless. So again, you're still homeless though, and you don't have somewhere to go, and you might not qualify for something that you do actually meet the criteria for just because you've been in a hospital or a jail, but those places aren't home.
Roberto, is it just this right foot that's bothering you right now?
Yeah.
So have you been to the hospital for this yet?
No.
Okay.
I just don't like
I know.
They don't want to stick you with needles, and I don't like needles.
Yeah.
And then they want to stick you in an IV, and they always miss my day.
Do X-rays or more or tests that we can't do.
Yeah, I'm not going to lose any more on my foot, because they took more off this foot than they did this one.
Yeah. Yeah.
And I don't know why they took more off this foot than they did this one.
All right, so we will try to make it over to the 300 block.
It's really difficult because we when individuals go into the hospital, we are removing a right from them. They have, rights to self-determination, rights to make their decisions, rights to take meds, or not take meds, rights to, or not to go to group homes that we want to send them to, the aftercare that we want for them. They have a right to say no to those things.
It looks like he's not answering. So.
Were they able to diagnose it, figure out what was going on with his eye?
Yeah, he's got a lot of hair. He's got cataracts, severe cataracts. Those are pretty easily addressable.
I think it's really important to know that safety and security is probably the #1 concern for those people living on the street. And when you don't have much, you don't want to leave it. So that becomes a very hard issue too. So let's say, for instance, I leave my campsite to go to work. There's a very good chance something or things are going to be missing by the time I come back. Or if my phone gets stolen and I don't have a computer to back it up, that becomes a much more complicated issue. We know a lot of patients that don't sleep well at night because they are scared for their own safety, and they're scared that they will lose what possessions they have. So I think those are all things that we take for granted when you can go home to a peaceful, safe environment that's private. Transportation is a big limitation here. You know, we have our bus system, but sometimes it might be a little bit far, the stops from where individuals live. Goes back to the issue of what am I going to do with my things as well when I go on this bus. And then another factor we've seen in why patients don't necessarily get better after they're discharged from the hospital is because they have follow-up appointments that they can't make it to. So they're discharged, but there's no way to get back to see your doctor again. And that's where, if we know about them and we've been able to work with doctors at different hospitals in the past, or ER departments or inpatient departments that have contacted us and said, hey, can you follow up with this patient? We're not a big enough team yet to do that on a regular basis, but if you don't have the transportation, how are you going to make the follow-up appointment?
It's very complicated to help them get connected to resources that are there, but there's that gap that is like, how do I get them connected? Because a lot of times once they're connected, they're getting good services and they're getting the care and the help that they need. Or once they have insurance and once they have disability, we can set up other resources for them that help them stay off the street and help them with their mental health and their medical issues. And while there are clinics that provide services to individuals who are experiencing homelessness, oftentimes there's long waits for those places. It depends on the organization, but sometimes you need documentation also to say that you're experiencing homelessness, so they're not going to charge you. Because obviously they need checks and balances so that, you know, not just everybody comes there and tries to get service for free. And so having us working with them is helpful because we can provide those documentations that they need to be able to get those resources. And then also documentation for helping fill out paperwork for disability. That paperwork is often complicated. And then you have appointments to go to. You will start getting appointments. You need to go to this appointment because disability wants you to. You don't have money, you don't have transportation. The bus system is complicated for you because of your mental health. And so you're like, how do I get to these appointments? You have to go to a probation appointment. You don't have transportation. How do you get to that appointment?
We had one patient at TTV that took a bus to the ER. He was discharged the same day, but he wasn't discharged till after 10. He missed his bus back to TTV. And because of what he has been through in his life prior to TTV, he was not going to lose his place by any means. That is his place to live in. But there was such an innate fear that if I don't come back here tonight, I will lose this place, even though it was unfounded, but it was because of all the past trauma he had been through. So that speaks again to security and safety that I think a lot of patients, in a lot of clients, it's going to take time to feel that and to build that. For women in particular, I think it's for men and women, but for women in particular, the abuse on the street is a major issue.
Let me tell you, these are some of the bravest females I've ever seen in my life. They are fearless. They will walk in the dark late at night by themselves. Some of the places they, crash and sleep, I'd be like, I wouldn't sleep over there, but they are some of the bravest, but even for them, it's dangerous, there are predators out here.
I interviewed one of our patients about a year ago as part of a study we were doing because we were trying to get into the hearts and minds of what brings people to the street and what keeps them there. And I will always remember this person I spoke with. Top 25% of her class in high school, started at UTSA on her own. She was paying for herself to go there. And her brother introduced her to cocaine for the first time. She was addicted, she said. She asked within 30 seconds to do it again. And she said, I was then hooked for the next few decades. As a woman on the street, if she wanted alcohol or drugs, she would have no problem getting them at any time. She said, that's easy. But if I wanted food, I would have to do a favor for whoever was offering me the food. And that included passerbys that would stop in their car and proposition her. And that really broke my heart to hear about that.
I have to deal with it every day. How do you deal with stuff like that? How do you bring it to a police officer's attention for help? So did this to me. are crazy, they're sick. How do you bring that to the police? How do you do that? That's sick.
It's all table runners and persons and whatever I could find. So.
Thanks for inviting us in.
No problem. But I know somebody living under a bridge and a tent. This is really not even a tent. It's 2 canopies pushed together. The walls are made of everything. T-Vex they put on the house to keep the moisture from the plywood. I found some of that a buddy of mine had. Curtains, tarps, whatever. Yeah. But no, nothing's done with the nail. Everything is zip ties.
Oh wow.
So when the city comes and says, we're going to bulldoze your place, I can take it down in a day, move it for the day, come back, put it back up.
How many times has that happened to you?
Oh, every 2 or 3 months.
We're hurting. We're hurting, all of us. If I had a stable roof over my head, yeah, of course. I would love to be back in a place I can call home. You know, I can close the door, lock my door, shoot the middle finger at the world if I want to, you know. We'll go somewhere and a week or 2 they'll come there and tell us we gotta go. You know, where we gonna go? They know we don't have anywhere to go. Where are we gonna go? So it's just a game they play, I guess, or whatever. You know, but they know we're not, where are we gonna go? You know what I'm saying? They tell us we gotta go. We're not gonna just go move into an apartment or a house. No, it's not gonna happen like that. We're gonna move somewhere till y'all recognize us again and then come tell us to move. Then we're gonna move somewhere else till y'all recognize us again and then we're gonna move somewhere else. I've been out here 5 years. Now, that's a lot of moving.
This is Town Twin Village where we're at right now. This is a new location. StreetMed became involved with Town Twin Village probably about a year ago, where individuals from off the street that were selected came here to reside, and they get choices between little trailers or these little houses, but they need to meet certain criteria. And those criteria are selected by a boards. Once they're chosen, they get little interviews and they can come here. We provide some of their medical care. They do have a medical facility here, but the staffing, like every place, is a little bit short, needing providers, needing volunteer. And honestly, StreetMed may know some of these individuals, may know their backgrounds, who are great candidates for helping them out. But typically what will happen is we will have a list or some names of individuals that we want to see on certain days. We'll come out, just check in with them, maybe do med refills, maybe do medical pre-op surgical clearances, little falls that they have, and really is just to continue relationships and care with the individuals. Hi, I'm Becky with StreetMed. Okay, good. Hey, we have some camera crews here.
Street's all right if you know what you're doing. I did. I was in the service, so I've been in worse places. So I stayed at that park right there and slept for about a year. The rules, I don't like the rules.
Yeah, you can put on.
You only can have 4 people stay here a month. I never heard of that in my life. But I understand.
Okay, and then the ibuprofen, I'm going to...
For my experience,
so 200 milligrams.
I wouldn't want to do it again. I'm too old, number one. It's rough. My brother died because he was homeless. He died behind Waterbury, behind San Pedro. Yeah, I told him to hold on, because he couldn't read or write. So I told him, I'm going to help you, but he didn't want to stay at Haven. So one day I get a phone call saying he's dead.
Yeah, so Town Twin Village has been in the works for years, and it's fun to see it finally coming to fruition. And it's a Housing First Coalition model, so their whole idea is we'll put a roof over your head and then figure everything else out, which is interesting, and I think there's pros and cons. So the traditional model is you get yourself together and meet this metric, and then we will provide this for you, and then you do this, and then we will do that. And that is kind of the traditional model, and it's good in some sense because it motivates people to make progress on certain goals, but it's also can be bad because if they can't meet those goals, then they can't get the help they need. So Housing First will flip that model with the idea that if we put a roof over your head, probably a lot of those other things are going to get better on their own. And I think many times that's true. So putting a roof over your head from a health perspective makes a lot of things related to hygiene and wound care and musculoskeletal issues of sleeping on the ground and in wet dirt and not being able to toilet and hygiene and fix food. All those things are going to contribute to poor health outcomes, whereas having a roof over your head with a toilet and a sink and a kitchen takes all that off the table. And so I think it actually can make a difference, but it's also challenging because a lot of those folks who come in, they still have their mental health issues, they still have their substance abuse issues, they still have their inability to, they're not used to managing a home and taking care of it. So it can be a little rough, and some of them still struggle. And are they going to be ultimately successful? I don't know. And if they're not, how do you what do you do in that scenario? And I guess the question is, ultimately, are they better off, even if they're not doing great, housed versus on the street? And that's kind of the ultimate question you have to ask yourself.
What's the number one thing you want me to help you with first?
All I really need is housing. Everything else, I can get. I'm not gonna tell you no story. That's all I really need is housing.
Okay.
For real.
And I'm going to be honest, there are some that might not make it. They're not capable. I tried to help an individual get an ID. She, due to her mental illness, she probably will never understand it, be able to go past those documents. So all we can do is our Father's house worldwide is love her. Do you got food? Do you got blankets? That's as far as she can go. But there are so many that once you connect that community and they see that, and you doing the assessments, saying this individual just needs that hope. This individual needs education, needs medical attention, needs psychological, emotional. We'll see a different individual grow. But it does take time, and it's walking with them.
I want to go back to work, but I can't. My foot. I got ran over by a truck.
Oh.
They took the fifth toe, the bottom one, and the fourth one. And they said I can't work. And I applied for my Social Security. I got enough benefits to get it, but they denied me the first time. And I got mad. I said, well, you got these young kids out there collecting $900 a month, never worked a day in their life, and you telling me no? That pissed me off. Because the lady said, you got enough quarters. You've been in a service, that's going to help you. But they denied me the first time, I got mad.
I lost my thumb in 2018. I'm left-handed, so I can't hold a pen. And because of that, I can't work. McDonald's refused to give me a job because I'm a hazard in the kitchen and I can't count money because I can't separate it. So McDonald's won't even hire me. Been with every organization, Sam's Ministry, CAM, all of them. And I'm in all their systems. But I'm white, almost 50, and a man, so I don't have kids, so I can just sit here.
When they had amputated my two toes, like I was telling them, the first toe was amputated at Baptist Hospital. But they left me there for a week. They didn't clean the wound real good, so I ended up passing to the third toe. So they had sent me to University Hospital. And since they had the foot specialist there, well, they had to amputate the third toe. And if they would have cleaned it, Baptist real good, I would still have my third toe.
Honest, we can try to drain a little bit of it out here. We have some of the numbing medicine to put in and a little kit to do it. Do you want us to try to do that? Okay, all right. Let me get that together for you.
I'm gonna feel poke and a burn, okay? Just kind of get a good feel of the area around here. Are you able to turn your leg or rotate your hip more so that this is upward facing? Good. All right, poke and a burn. me know if there's any discomfort, okay?
If this hurts, just tell us. We'll stop when maybe it's more, but some stuff out.
Okay.
Already cut it, yeah. It's already cut open and draining out.
These pus pockets, these abscesses, they're like more like raspberries, right? They have these little clusters on them, and each one's kind of separated, and you want to break them up so there's no leftover infection. It's not like a grape where it's like all one thing, you know?
So mostly was not too much infection in there, right?
Most of it's been blood. There are some like debris that's, who knows what. Maybe the first little bit there was a tiny bit of pus, but this is still pretty much consistent with like what I'd be concerned with an abscess infection or something. Especially with the story of being red and whatnot.
Right now. Do you have any kind of fevers? Really wasn't catastrophic. Do you have any kind of fevers too? No, not recently. Can we talk to you? Yeah. It's dirty because there's parts of my leg I don't have any nerves on, you know?
Yes.
Or maybe part get itchy and I scratch it.
How's your sensation down here?
Very good, very good.
On all sides?
Yeah, it's really more top of my foot. It's like, I can feel, and yeah, that's like background. Sometimes it's really bad. Yeah, no, you just have to rubbing alcohol.
Can you feel the wound very much?
Once you guys there? Yeah. But you know, inside the wound, I don't really have any sensation.
If at any point you're not doing okay, you let me know, okay?
Yeah.
It's just dead tissue. We're gonna try to get rid of.
Some of it's kind of deep in there.
Did that hurt at all?
It's right at the end.
That right there is HEPA cleanse. It's pretty strong soap, so it's gonna sting.
Yeah, there's no possibility of like you getting like maggots and stuff, is there?
There's always a possibility. I would
Keep
say.
it clean.
Yeah.
They do have a lot of needs there because of the nature of the business. So Town Twin Village focuses on the most vulnerable, oldest people with the most comorbidities who are living unsheltered in the city. So they're basically looking for people who are struggling the most and bringing them in and getting them off the street. So because of that, it is a rough group of people dealing with a lot of things. And actually when they first opened, they actually approached us and other partners and said, hey, who do you know out there who we should prioritize getting a roof over their heads? And we definitely had some people who I think probably wouldn't have survived more than a few more months out on the streets, who are now sheltered there and doing better because they had that opportunity. So that's been good to see.
Hey Paul, how are you? My name is Amy. I'm with Street Medicine. I heard you might have a wound that we can take a peek at and help you out with. Is that okay?
The ones that have become housed still struggle, and I think there's a large percentage of our population that is probably 1 or 2 paychecks away from either not being housed or they just recently got housed, but they're not used to those accommodations. They're not used to sleeping on a bed. So we've met patients that still sleep on the floor, even though they're in a house, because that is their comfort zone and that's what they're used to. You know, there's a big mental health and social services kind of occupational therapy aspect to street medicine and working with the unsheltered population in terms of how do we conduct these activities of daily living. First, for the physical ones, of course, but then also, how do I make a doctor's appointment? How do I contact a bank and work through that if my money gets stolen, for instance? There's all these things that there's that extra step of help that we have a lot of need for and limited personnel right now. So even when you are able to get off the street, your problems aren't solved by any means. And there's a whole reintegration process that has to happen that I think would be very hard to do on your own unless you had a very strong support network.
In the meantime, you know the deal on the wrist. Very light range of motion. Obviously, you just heard it. There's a lot of inflammation. There's going to be pain. So you can elevate it and ice it. If it's no better by Monday, if it's getting worse, X-ray.
Yeah, I'm going to give, well, I've got this little where I can put my cold water in.
Mm-hmm. And then what's your homework?
Clean my bedroom.
You, not your lady friend. Right?
Yep.
Okay, good deal. All right, my friends. Nice to see you. Good seeing you.
Yeah.
Tell your friend Kevin I say hi too.
Oh, I will.
Okay.
I believe when people start to have that confidence again, when they start to see things work, when they start to see organizations stay in touch with them, it can make a really big difference in someone's life. And And with a history of severe emotional, physical, and other types of abuse, again, the journey's not over if you get housed. So for many individuals, this is going to be a lifelong journey. But it's a step forward, and that's all we try to do. We're just like our patients to just know you can just take one step forward at a time.
Excuse me. I could go get you a cup of water. That's right. That way I'll go get you a cup of water and give them some time to go ahead and get you addressed with them, so they could address your wound or any other medical concerns you had.
It's not hurting her.
How long has it been there? Do you mind me asking that?
For at least a couple months.
A couple months. Have you ever been given antibiotics or any treatment for it?
I take it right now.
You're on antibiotics? Who gave you those?
The hospital.
The hospital. Which hospital did you go to? Do you remember?
I forget the name of it.
No worries. One of the concerns, I think, it may be doing better and that would be amazing, but when you tell me it doesn't hurt at all, another concern is sometimes there can be damage so deep that we don't have pain anymore.
Give me a card or something.
I will, absolutely. I carry antibiotics on me. We can check your vital signs. We can check your sensation, your movement, and everything. But it's something I can do today, but if you don't want to, I completely respect that. But me or one of my team members can do it in the next few weeks as well.
Not anybody can just walk up and be part of our circle. It don't work like that. We're tight knit. We go through what we go through. Just like regular people, regular families. I grew up in a household with 3 brothers by my mother, and it wasn't until I became homeless that I knew what it was to have a brother. We're human just like everybody else. We just fell on our luck, but we still like to do things that normal people do. We wear the best of clothes, the best of shoes. We're not the new breed, the homeless. It's not who we are. We're human, just like everybody else. People look at us and want to stereotype us and things like that, but we're no different. We're not animals. We're human beings that happen to live on the street, don't have a roof.
I go around and do my scavenging, but I do enough and go to enough food banks. I feed 8 to 11 people a day. People stop out here all the time asking if I have something to eat, and I feel horrible if I don't, so I keep stocked up just to feed everybody. So, like I said, one of the things I'm most proud of is not turning into other people. I don't want to be like everybody else. I want to stay true to who I am, and I get frustrated that everybody that sees me treats me as him, and that's not fair. And both the state doctor and state medical doctor said there's no reason I shouldn't be.
Was it from the San Antonio State Hospital, or do you remember the name?
What state hospital? You keep saying state hospital. I haven't been in a motherfucking state hospital.
Okay, well you said the state, so what do you mean by that?
The state doctor? Because when you go and apply for disability, you have to go see their doctor. That's the state doctor.
Okay.
Do you get that?
Yeah, I understand that. Yeah, so that makes sense now.
Okay, I'm glad you got it, because that's really kind of irritating.
I apologize.
This is a group of people who have been let down over and over, whether it's by their family, society, all the above. So definitely the first time we go out and engage with somebody, usually it's somewhat standoffish, and it's a population where you kind of have to prove that you're who you really are. Then when we come back the second time, it's usually like, wow, you came back, and we're greeted with a different level of interaction. And by the third time, they're like, oh wow, you guys are really coming out, and you're not getting paid, and you're not. Oh, okay, I get it. And so a lot of it is just, proving that you're dedicated and you're going to come back and that you care. And I think that word gets out. These folks talk in their community around them. But I think the biggest thing is just approaching with dignity and coming back and continuing to say, look, if you want us to come back, we will keep coming back and we will keep trying to work on whatever you've got, and we're going to be honest and we're going to listen to you. And I think those things are what really proves your worth. And then they start talking to their friends and whatnot, and then you become a welcome member. But yeah, it's the first time. There's definitely some who do you guys think you are, and I think we have to respect that and understand where they're coming from and not be turned off by that. This is who we are, and we'll come back, and we're just here to help you.
Not everybody can play the parts that are dealt to us, but those that play them out well are the survivors, are the ones that live through the trauma, are the ones that live through the abuse, they live through the hunger, through this. Look at this. Really? I'm sure this is not the way God wanted me to live, but this is where I am. I gotta make the best of this, because what else do I have? It's horrible. Nobody really cares about homeless people. No matter where you go, you get discriminated. You can't go to a store or I would use a restaurant because you gotta buy something. Okay, so if there's nowhere, a convenience store where do I go to a restaurant at? Under a bridge? Come on, I have 4 walls and a toilet for me to go do anything. You know what I'm saying? It's hard out here. They're discriminating against you every day for no reason at all.
I have to play the cards I've been dealt. I don't make excuses. I make things happen for myself. Even out here, we have to wash our clothes. We have to groom ourselves. We have to eat. We have a daily living expense. Every time we go in the store, they charge us. We don't get nothing free. We have to pay for everything. So we have a daily living expense also. We're normal. We're normal people. I try to make sure every day that I live, my good outweigh my bad by far. I just want to do good, and I just want to help people, and I just want to be there for people. If I could change the world, I would. If I could fix everybody, they would be fixed. I can't. I can only fix me. If I could help one person along the way, mission complete. I've done my job. So many of my peers out here, and the younger ones, they come to me for advice. They come to Kool-Aid for everything. Go to Kool-Aid, go to Kool-Aid. I'd be like, Lord Jesus, what? But God, created it that way. I welcome it like that, They depend on me and I'm there for them. It really makes me feel good. Yeah.
Globally, probably the biggest problem is that people don't have access to healthcare, and it's usually a monetary issue. So lack of healthcare insurance, lack of resources, not just for the unsheltered, but for a large segment of our population, especially here in Texas, is really the underlying problem. And there's some fairly easy ways to address that, I think, that every other developed country in the world has figured out, except us, but we continue to struggle with. And so those discussions are actually very fun and helpful with our learners to talk about healthcare equity and the healthcare system. And so I give them books to read and encourage them to get fired up and educated on why the healthcare system they're going to work in is so dysfunctional for so many people, because it really is, and that there are, it's largely the way that it's set up, because it works the way it does because it has been set up that way. And we talk about things like that Texas leads the nation in the uninsured rate, and why is that, and what contributes to that, a large portion being that Texas is a non-Medicaid expansion state, and why and what drives that.
First things you said is that San Antonio is different from other street meds. Like, it's on a volunteer basis. Is there any reason as to why that is? What makes San Antonio so different?
Yeah, because we don't have any money. That's what it comes down to. And that can be good and bad. So street medicine in other cities is often funded by the city, by medical schools, charities, or some conglomeration of those. In San Antonio, that's not true. We're self-funded. We have no outside money. So because we don't have a lot of money, we can't pay full-time staff, we don't have a clinic, we don't have cars. So we do have a storage area. We get donations and supplies. Sometimes we buy them, sometimes they're donated, where we keep all of our supplies and equipment. None of our staff is paid. We all use our own cars. So it's a very kind of shoestring budget model. The upside of that is that with money often comes strings. So if you get a grant or you're funded by an organization, they're usually going to want you to align with certain metrics, compliance issues, reporting, and organizational goals that they have, which is totally understandable. But those might not always align perfectly with what we're trying to do. So there's an immense freedom for us to decide who we're treating, how we're treating them, and how we're operating, because we're beholden to nobody but ourselves. So will that change over time? I don't know. I mean, we've looked at, we've gotten some small grants already, and we're looking at getting more, and we're looking at other funding sources, because there's definitely a limitation to being all volunteer, because we all have day jobs and don't do this full time, that we have limited capacity, and that's a definite limitation. And if we want to really expand, having full-time people who are paid to do the job is really the way to go. But as we do that, then we're going to probably have to become more structured and have less flexibility in some respects. And ideally, I think we'd preserve some aspects of both models and preserve the ability for people to volunteer and preserve as much autonomy and flexibility as we can. So I would hate to see us kind of become just another bureaucratic, locked-in group, but I'd also like to see us have more capability, and so we're trying to navigate how we preserve the best of both of those worlds. How's everything else going? You okay? All right. Well, it was good seeing you. We'll keep checking on you. And
everybody wants to be noticed. You know, everybody wants to be loved. And this is a group of people that are unloved. You know, whether their family kicked them out, whether they left, or, you know, just life beat them down. You and I would be doing the same thing that they're doing if life treated us the way they life's treated them. And so to show somebody that love and look them in the eye and you talk about their name or use their name and help them with self-respect and self-dignity, you know, that's huge. The people on the street are ignored. Nobody wants to talk to them. And you just look the other way. You know, somebody's flying a sign at the corner, you don't look that way because you don't want to make eye contact. So they're ignored. And it's almost like they're non-people. They can't trust anybody. But when they can trust us, and we bridge that gap of caring, and like, wow, these people really care about me. Nobody else, their families, nobody else may really care about them. And when you have that, and they can rely on, they'll come and talk to you and they'll say, I need help. I've got to get out of here. I got to get off this stuff. And we're there. We make calls, I took guys at 5 o'clock in the morning, go into the methadone clinic, pick them up and go to the clinic, you know, so they're not shooting up. And so it's that caring and loving somebody. That's what it's all about.
When I've heard people say they're just an addict, or they're just someone that's experiencing homelessness, or maybe they say that they're lazy, I think like starting to work on changing their language, right? Like even how I say this is someone who's experiencing homelessness, it changes how I see that person. If I just say you're a homeless person, I would see you differently than if I say you're experiencing homelessness or you're struggling with addiction. If I say you're just an addict, that comes with somewhat of a negative feeling, right? And if I say you're struggling with addiction, one, it gives you hope, and it also makes me see you differently. I think like if we just see people as just someone with addiction, or just someone with severe mental illness, or just someone who's homeless, like then you lose like their humanity.
And that is a very big component of street medicine. It's definitely patient-driven care. I think a lot of medical models definitely aspire to that as well. But in our world, that trust, communication, relationships, I would say is even more important than the medicine. Because if we don't have that, we're not going to get anywhere. And when you deal with many people that have been through so much past trauma, that's not an easy feat for them to potentially trust someone. And to know that we're not doing it for any secondary gain, but we are just doing it because we believe that you and I were made in the image of God, and we are here to support and to love each other. And we're just gonna be one small piece of that, but we're gonna do what we can, and then we will be back too. And I think that's building the trust that you will come back, because there's a lot of abandonment concerns, abandonment history for these individuals.
We don't want to be out here. I mean, but we're out here, so we deal with it. But help us, you know, take out a budget, give us some housing or whatever.
You know, there's really no chance to be able to survive living on the street whatsoever. Not even for one night, not for one day. You're almost guaranteed if you're anywhere trying to even just fall asleep outside for like about a couple of hours, like during the daytime, you're definitely at risk of getting injured or getting, you know, hurt in some kind of way. So I'd say just, you know, if you run into a situation where you're outside and you don't know what to do and you need somewhere to go, it's just best to find the right services and the right places to get the services.
Homelessness is not a choice. Really, it isn't. People say it is, but it's not. No, I don't think nobody wants to live out here in the streets. No nowhere to use a restroom, no privacy, nowhere to have a comfortable sleep without somebody coming up to you and trying to do things to you while you're sleeping. One change can make a big difference for a lot of people. One simple thing. It could be a nice, kind word, a gentle hug, I care, someone loves you. People need to hear those things. It's healthy for the heart and the soul.
A lot of times they'll form little communities in their camps and try to take care of each other, which is admirable, and it's really great, I think, when they do reach outside of themselves and try to help others, because for all of us, that's when we, I think, are at our best, but they have limited capacity and capability to do that. But it is nice when we get referrals from other camp members or peers. Sometimes they'll message us, hey, Joe needs a wound check, and we'll come out and check on him. So that is definitely a referral source for us, is other people in the camps looking out for each other and asking us to come out and help. Oh, it's great to see people do well, and I mean the ideal scenario, and we have this happen a lot, is people don't need us anymore, and that's wonderful. That's the ideal, but it's tough. I mean, they'll go through their ups and downs, and sometimes people do better for a while and then have to come back to us, which is fine. But the goal really for us is to transition them, if they need long-term care, into a clinic. We're really just kind of a Band-Aid to help them seek help. I don't think we're intended with a backpack to be a long-term solution for people. But sometimes we are, and if that's the case, we'll do it. But the real goal is to get people to transition, either to establish medical care and or to seek the services they need to get better and get off the streets.
Nice. Good. Awesome. Good.